Hi, everybody, and welcome to a Prasiska GI Cancer-Focused Tumor Board. My name is Sam Klepner. I'm a GI medical oncologist at Massachusetts General Hospital in Boston, and I'll go around as I see it on my screen. So I'll start with Dr. Siegel.
Good afternoon. My name is Carrie Siegel. I'm an abdominal radiologist at the Mallinckrodt Institute of Radiology at Washington University in St. Louis.
Hi, everyone. I'm Pritesh Patel. I'm an associate professor of radiation oncology at the Winship Cancer Institute at Emory University in Atlanta.
Hi, I'm Marty Weiser. I'm a colorectal surgical oncologist at Memorial Sloan Kettering Cancer Center in New York.
Hi, I'm Al Benson, and I'm a GI medical oncologist at Northwestern University in Chicago.
So this is a 79-year-old woman who presented with urinary retention with imaging showing a large rectosigmoid mass, colonoscopy and biopsy confirming a moderately differentiated adeno. Patient was status post radiation as well as what looks like FOLFOX or CAPOX followed by FOLFIRI. We don't know the exact reasoning. Declined to surgery and now has a rectovaginal fistula. So the specific questions are about options to improve continence via the fistula and options for management of a fistula. And so this is probably going to come into the radiation and surgery world pretty quickly. So the history that's available, this woman presented with retention and then stool from the vagina and significant skin irritation. ECOG was compromised to some degree with the ECOG performance status of 2. Patient is status post a prior hysterectomy as a current smoker with occasional alcohol use. There's an MRI which we can review. The colonoscopy had a biopsy again with the invasive adeno. Patient got 6 treatments of radiation in 1 month. Again, don't know the details. Was also treated with oxaliplatin, leucovorin 5-FU, followed by irinotecan, leucovorin, and 5-FU. Declined a follow-up surgery or colonoscopy, it sounds like, and then recurred with a rectovaginal fistula. So let's get into the available imaging here.
So this is a high-res T2 weighted view, and there's just a very large multilobulated mass in the pelvis. It's helpful to know she's had a hysterectomy because the mass is so large it's almost disorienting. But if you look at the anterior aspect of the mass, it's extended into the bladder beyond the serosa through the muscularis into the bladder wall. And then the posterior aspect of the mass, there's a large fluid collection in the vagina. And if you move forward one slide, this mass, again, just showing a large amount of involvement of the bladder wall and the vagina, and it's a sort of a high rectosigmoid mass. And the final image, which is an important one. If you look at the directly anterior to the rectum is the vagina, and I'm not even sure it would be most optimal to refer to this as a rectovaginal fistula, as a significant portion of the anterior vagina is gone and is freely communicating with this large mass, and that large hole in the anterior vagina communicating with this large pelvic tumor, it might be important for the clinical team to know this in terms of planning some sort of a treatment.
Thank you. And as is not uncommonly the situation, we don't have all the details when we're asked to weigh in on the management. So we don't have the timeline, we don't have the radiation dosing, we don't know some of the intervals here. But broadly, this is a really tough clinical problem. So I'll start with Dr. Patel and Dr. Weiser in terms of what are the options just for management of tumor-related fistulas, maybe broadly. Dr. Patel, you can start.
So this would be, a question, I think, of re-irradiation with unfortunately local progression of a recently radiated tumor. In this particular case, I think based on what Dr. Siegel just described, which is a pretty wide open fistula, it's very unlikely that re-irradiation would have much clinical benefit. as it relates to the fistula. And this would certainly be a case where I would be very interested in Dr. Weiser's thoughts and hopefully an option surgically.
Yeah, so in a 79-year-old smoker, how would you talk to this patient about surgical options or procedural options?
So it is a tough problem. A lot would depend on her functional status and things like that. She'd have to be sort of fully evaluated if she were willing to have surgery. The most minimal thing she would need would be a colostomy. There is no way to control the fistula otherwise, and she will suffer greatly as she excoriates her perineum, as well as develop likely upper tract infection in the GU system, leading to sepsis. The best case scenario, if she were medically fit and acceptable of a big operation, would be an exenteration where we remove the rectum, vagina, and bladder, and we would have to give her a colostomy bag and urinary diversion. Without evidence of metastatic disease, there is a very good chance we could get clear margins if we do a wide resection. So I would urge her to consider this if she'd be willing to do it. We'd ask if we could get any tumor shrinkage with additional chemotherapy. I suspect the answer is no, based on that she's gotten first and second line already. But I would want to know from you if there were any options there to help ensure a complete resection if she were willing to do it. Before that, getting back to her fitness for surgery, it would be critical. It's a very large operation. It would need plastic surgery reconstruction, usually a 1 or 2 week hospitalization with 3-month convalescence. So it's a big deal that she would have to be willing to undergo. But do we have any options to help shrink this tumor before surgery?
Yeah, I'll start with Dr. Benson there. So presumably this patient got FOLFOX and FOLFIRI. Again, don't have the timeline, but would you have a realistic expectation of chemotherapy role here?
No, unfortunately, I don't think we would get the level of shrinkage that you would like to see. Just as an aside, although not likely, we would want to make sure this wasn't an MSI tumor. I mention that because I just had a case, not quite this severe, of someone with a very large tumor, and on single agent immunotherapy, when she then went to surgery, there were no residual tumor cells. She had a stunning response. But outside a situation like that, I don't think we can expect our available systemic therapies to provide meaningful shrinkage. I suppose if she had a RAS wild type tumor, we could consider combinations with either cetuximab or panitumumab. But again, expecting a really good response, I think, is unrealistic.
Yeah, I agree. Sometimes we get lucky with these sort of large local tumors being MSI in the older patients, and that would certainly be about the best thing that could possibly happen for her. Maybe just briefly, Dr. Benson, since you raised the issue, if she was MSI, presumably you'd give her single agent therapy, and maybe just for the listeners, maybe highlight the Keynote 177 data just to support. Granted, it's not this exact same situation. The patient is not newly diagnosed, but maybe a brief overview will be helpful for everyone.
Well, I just think, you know, as we move forward with our understanding of immunotherapy and moving immunotherapy in the frontline setting with chemotherapy, and this particular trial did show the benefits of combined chemotherapy and immunotherapy, and I think this is now merging into a standard of care. for people with MSI positive tumors.
Yeah, and at your institution, are you broadly characterizing these, locally advanced / metastatic patients with next generation sequencing? Are you doing single gene tests? Just a topic. I know it's getting a little bit off topic, but
for the most part, I would say certainly our metastatic patients receive NGS testing. You alluded to other types of assessments, such as looking at circulating tumor DNA in ways to not only determine risk for patients, for example, in the post-op setting, but also as a measure of response to treatment. This is just an expanding field, but increasingly NGS testing is important. And also, we occasionally see these very rare situations like NTRK fusion. So we're, routinely testing people, and certainly looking, right now it's just standard pathology reporting to include MSI testing. It's on all of our colorectal reports and many of our other tumor types also.
I completely agree with everything you said. Maybe just to wrap this case up and actually wrap our entire tumor board up, maybe Dr. Weiser, what would you tell this woman if her expected course if she didn't do anything? Because it sounds like she may have been a little bit resistant to some recommendations in the past. What's going to happen to her?
Yeah, I suspect she's suffering currently with the amount of drainage from her perineum. And I'd urge her, at least while she decides to have a colostomy brought up laparoscopic, to allow the perineum to settle a little bit, and then she could consider her options more fully. But this sort of pelvic disease, which has not metastasized, it's a large tumor, probably won't metastasize, will cause tremendous suffering. And this would be the type of procedure even we would consider a palliative exenteration, which is a big operation if we're not going for cure. But because the amount of pain and suffering will be so large that it would be something to think about.
Maybe just final question for Dr. Siegel. In imaging fistulas, in maybe a more general question, this one's obviously apparent quite clearly on MR, but in maybe a more occult situation, are there types of imaging studies that can be helpful?
There's a lot of different imaging options for fistulas. MR in this case, CT, and even different types of conventional, either a barium enema or a VCUG, depending upon, or even a vaginogram occasionally, depending upon what we want to know. In general, I would say we get the most bang for the buck with the MR, especially with complex fistulas. And we're not, it's less invasive for the patient. We're not injecting them with contrast in their vagina or contrast in their rectum. And so I tend to prefer that in some situations. But in some situations where the fistula is subtle or difficult to characterize, the surgeon really needs to know the exact level where it's at. We will sometimes go to either conventional urography or a conventional water-soluble enema, or even rarely a vaginogram. So I'd say I prefer MR, but I think CT is good. And in certain situations where really detailed anatomy will be needed and the cross-sectional imaging might not be enough, we'll go to conventional imaging.